Welcome to While We Were Distracted, the podcast where we explore topics that often get overshadowed in the rush of daily life.
Today, we're tackling something that I think frustrates almost every American: healthcare.
Hmm.
It's a system that costs a truly staggering amount of money. I mean, way more than any other wealthy nation.
And yet it just doesn't deliver.
Not even close. Our sources really laid this paradox out. Just look at the raw numbers. The U.S. spends about double what other wealthy countries do per person.
We're talking nearly $15,000 a year for every single person.
15,000. While their average is what, around 7,000?
Just over 7,000, yeah.
Yeah.
And as a slice of the entire economy, our spending it's just huge, almost 18% of our GDP.
Compared to an average of 11% for them, it's a
Yeah.
massive difference. Okay, let's unpack this.
Right.
When you spend double the money, you should get, at least slightly better performance, but our health outcomes are often worse. So what is going on? What's driving that cost?
That is the core question, and for decades, researchers have been trying to pin it down. The sources we looked at, though, they give a surprisingly direct answer.
It's not as complicated as we've been led to believe.
Not really. For years, the debate in the U.S. was all about our system being mostly private versus their universal systems.
But the data tells a different story.
It does. It's not just about who insures you. It's about what we pay. The finding, which is now famous in economic circles, is that our high spending is driven almost entirely by one thing:
Prices.
prices.
Right. It's that conclusion from our material. It's the prices, stupid. And that just completely flips the script on the conventional wisdom here.
It really does. Because for decades, the main strategy here was to focus on utilization.
Meaning we thought Americans were just using too much health care.
Exactly. We assumed people were going to the doctor too much, ordering too many tests, staying in the hospital too long. So policy was all about trying to restrict access to cut costs.
And that was just the wrong diagnosis from the start.
Completely wrong. The truth is, utilization rates in the U.S. are, well, they're often average, sometimes even lower than in peer nations.
So we go to the doctor less often?
Fewer physician visits per capita, and our hospital stays are, on average, shorter. We aren't using more services. We're just paying 3 or 4 times more for every single one.
For everything, from a pill to a major procedure.
Everything.
And this cost isn't just high prices for care, it's compounded by this unbelievable level of structural waste.
This is the part that is just shocking. If you look at administrative overhead,
Yeah.
All the paperwork, the billing, the insurance complexity.
Bureaucracy.
Yes, the U.S. spends over $1,000 per person per year on just that.
Wait, say that again? Over $1,000.
$1,000, which is roughly 5 times more than the average wealthy country spends on administration.
5 times. Just think about what that means. $1,000 per person. Our sources put that in a stunning context. We spend about the same amount on paperwork as we do on long-term health care.
That's the funding mismatch right there. It's incredible.
It is.
Compare that to a country like Sweden. They spend 22 times more on actually caring for their elderly and disabled than they do on administration.
Our system prioritizes paperwork over people.
At the end of the day, yes. And this is why the analysis is so clear that price control is the only way forward. All those years we spent trying to manage utilization with things like pay for performance.
All those complex schemes to, reward doctors for seeing fewer patients.
They've largely failed to contain costs. And, we often hear that our fee-for-service model drives up costs. But plenty of lower-income countries use that model.
What's the difference then?
The difference is they control the fees.
So we pay double. It's driven by prices and waste, and we've been trying to fix the wrong part of the problem.
Okay.
So let's shift from the cost to the results. Because despite all this money, we are not getting healthier.
Unfortunately, no. America's outcomes are consistently behind our peers. The biggest one is life expectancy. Even before the pandemic hit, U.S. life expectancy was almost 4 years shorter than the average in comparable countries. We were at 78.8 years. They were at 82.7.
And if we connect this to the bigger picture, the pandemic didn't just expose these problems, it made them so much worse.
It widened the gap dramatically. COVID caused U.S. life expectancy to drop by almost 2 full years.
2 years. And for other countries.
The average drop was less than half a year. So by 2023, while we had a little rebound, we were still over 4 years behind.
And this isn't just about one virus.
No, it's tied to high rates of premature death from preventable causes. Heart disease, diabetes, and tragically drug overdoses.
And when you drill down into specific groups, the disparities inside our own country they're just tragic, especially maternal health.
It is the most sobering statistic in all of this. The U.S. has the highest rate of pregnancy-related deaths of any peer nation. It's 18.6 deaths per 100,000 live births.
And the average for other wealthy countries is?
It's 5.1.
So we are more than 3 times worse.
More than 3 times. And the disparity internally is crushing. The maternal mortality rate for Black mothers is about 3 times the rate for white mothers. And that holds true no matter their income or education.
These outcomes have to be connected to structural problems too, right? Like just being able to see a doctor in the first place.
Absolutely. We have a fundamental workforce shortage. The U.S. only has 2.7 practicing physicians per 1,000 people. The peer average is 3.8.
And it's not just any doctors, it's a specific kind of doctor we're missing.
That's the key. Only 12% of U.S. doctors are general physicians, primary care.
That 12% figure seems incredibly low. Why is that so important?
It's the key to prevention. Without enough primary care, you can't manage chronic diseases like diabetes or heart failure effectively.
So people end up in the hospital for things that could have been prevented.
Exactly. Avoidable, expensive, and dangerous hospital stays. The whole system becomes reactive instead of proactive.
And even getting an appointment is tough. Less than half of Americans can get a same-day or next-day appointment when they need one. And that's before we even talk about mental health, where the psychiatrist shortage is even worse.
It's the lowest among all peer nations.
Here's where it gets really interesting. So the problem is defined. High prices, massive waste, terrible outcomes. So Congress recently introduced this major piece of legislation that tries to fix it by going straight for the root cause.
Grace control.
Exactly. We're talking about the Medicare for All Act of 2025.
That's right. Introduced in the 119th Congress. And it's a direct response to this paradox. It would create a universal, single-payer program.
Universal entitlement. Every U.S. resident gets covered.
Every single resident. And the benefits package is.
Yeah.
It's incredibly comprehensive.
More than just standard hospital care.
Oh, much more. It covers all medically necessary care, hospital, outpatient, full mental health, and substance use treatment. It includes comprehensive reproductive care, so abortion, gender-affirming care, and crucially, it fills the big gaps in current Medicare.
You mean dental and vision?
Dental, vision, and audiology. Everything is included.
And for the person using the system, the biggest change would be what? The cost at the point of service.
That's the goal. Remove the financial barriers to getting care. The bill prohibits patient cost sharing.
So no more premiums, no deductibles, no co-pays.
None of it. And it also bans balance billing.
For anyone who doesn't know, balance billing is that surprise bill you get after a procedure, right?
Exactly.
Mm.
When you go to an in-network hospital but get seen by an out-of-network doctor, the bill bans that completely. Providers can only get paid by the federal program.
Is there any situation where a patient pays anything?
There's one potential exception, and it's for prescription drugs. But even that is designed to be affordable. There's a cap at $200 a year.
$200 a year total.
Total. And that entire cap is waived for anyone with a low income, so basically anyone at or below 250% of the poverty line.
Okay, so if it's universal and essentially free to use, how does the bill actually lower the country's total spending? Because you could just inflate costs even more if you don't control the prices.
Exactly, and that's where the price controls come in. This is the core of the whole thing. The bill achieves its savings through centralized pricing and budgeting. For hospitals and nursing homes, payments would shift to global budgets.
Okay, so instead of the hospital billing for every single procedure,
They get a fixed operating budget, a lump sum, paid quarterly to cover all their expenses.
and that's negotiated every year.
Negotiated annually based on their historical patient load, their capacity, staffing needs, things like that. It completely removes the incentive for hospitals to maximize profitable procedures.
And what about individual doctors, the ones not in a hospital?
They would still be paid through a national fee schedule.
Mm-hmm.
So it's still a fee-for-service model for them, but, and this is the critical part, the fees would be standardized and controlled at the national level.
And the biggest driver of all, prescription drugs.
Addressed head-on. The Secretary of Health and Human Services would be required to negotiate prices for all drugs, supplies, and equipment every year.
That national negotiating power is the key mechanism other countries use.
It's indispensable. It's how they keep their costs low.
So a change this huge can't happen all at once. How does the bill propose to actually roll this out?
It's a phased approach over up to 4 years. Some changes would be immediate, Within a year, for example, current Medicare beneficiaries would see their benefits improve dramatically. Zero deductibles, a much lower out-of-pocket cap.
And what about for everyone else during that transition?
There are a few bridge measures. One is a temporary buy-in that lowers the Medicare eligibility age in steps first to 55, then 45, then 35.
Kind of a gradual on-ramp.
Exactly. And there's also a temporary public option, a Medicare transition plan, that would be offered on the exchanges while the full system is being built. The bill also sets up new offices focused on things like health equity and boosting primary care access in underserved areas.
So this whole deep dive has really laid bare this central contradiction of U.S. healthcare. We pay vastly more than anyone
For worse results.
for significantly worse results, and it's because of uncontrolled prices and just staggering waste. This legislation seems to be the first major attempt to pivot the entire policy debate away from restricting use and toward controlling price.
And that price mechanism is the absolute key takeaway for you. The data is clear. Real solutions have to address pricing. We've spent decades trying other things, managed care, utilization caps, and the crisis has only gotten worse. This proposal is a direct response to that diagnosis.
So what does this all mean? The economic reality isn't really in dispute anymore. Cost control depends on controlling prices, a strategy that's been, politically off the table for decades. So you have to wonder, now that the problem has been so clearly diagnosed and a comprehensive cure has been written down, what happens next? Can the political system actually implement something like nationwide price control? That's it for this deep dive. We appreciate you joining us as we unpack the crucial economics behind U.S. healthcare and what the road ahead might look like.
Don't forget to like and subscribe for the next episode on While We Were Distracted.